إليه من ربه والمؤمنون كل آمن بالله والملائكة وكتبه ورسله لا نفرق بين أحد من رسله قالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحمل ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين صدق الله العظيم.
On behalf of Pakistan Society of Gastroenterology and GI Endoscopy and Chairperson, Department of Surgery, Dow University of Health Sciences and Medical Superintendent, Civil Hospital Karachi, I welcome you all to the 5th hands-on colonoscopy training course, which is being held in collaboration with West Midlands Endoscopy Training Centre, UK. We are very fortunate to have renowned national and international faculty for the course. A brief introduction of our faculty. We have Dr. Waqar Ahmed, who is a consultant physician and gastroenterologist, Gannad Hospital, UK. Thank you, Dr. Waqar, for coming. And we have Mr. Paul Hagen, who is a consultant colonoscopist and an endoscopist at Kingsmill Hospital, Mansfield, Nottinghamshire, UK. Thank you very much, Paul. In the national faculty, we have Dr. Saad Khalid Niaz, who is again a consultant gastroenterologist. He is a visiting faculty and director endoscopy at Surgical Unit 4, Civil Hospital, Karachi. I would like to request Dr. Saad to please come and give a brief introduction of the course.
Assalamu alaikum, everybody. We go through this every year, in fact twice a year. We give you a brief background of how did we come to where we are today. It's getting a little bit of, it's getting repetitive for us who are here twice a year, but unfortunately for those of you who are here for the course, it's important to know that a few points about the course I think you must know. It goes back, now this is the 5th, so it's almost 2.5 years when we started the hands-on courses almost, and I'm very happy that we've reached the 5th one. We're doing 2 courses a year. In colonoscopy, we have kind of delayed the ERCP course intentionally. I think the need and the availability of facilities in the country kind of forced us to do that. It's a long journey, quite a few years. Waqar, who I've known for a very long time from UK, we wanted to do these courses because they've been done in UK for a very long time, and it's very important when you are embarking upon doing something to know the fundamentals correctly. Because if your foundation is strong, proper, then whatever you're trying to construct and build will be worthwhile. So this course is intended to give you the right foundation, the correct way of doing things. This is not obviously intended to make you an expert, whatever an expert means, but it is to make sure that you know what to do, how to do, and what not to do. And we hope that in the next 3 days you'll be able to grasp these fundamentals about colonoscopy. Some of them apply to all endoscopic procedures. The basic fundamentals are very similar. In my opinion, the things that I do, and I do the whole range of endoscopic procedures, colonoscopy is the most tricky, probably the most difficult procedure that I do. It's very challenging. It's not about putting a tube through another tube. That's what I've seen many people do. It's a lot more than that. Doing it safely, comfortably, in right time, and not missing anything is very important. These are the things, these are the targets that you have. And a lot of things that you have seen being done in your units, they may be challenged here. There is always more than one way of doing things. What we try and do is basically give you the principles that are accepted by everybody. The way colonoscopy should be done is the way we are going to tell you here. It may differ from the way you've seen your seniors do it. I don't know if I can say that that's incorrect, but that's not the general practice all over the world. So it's important for you to see the differences and then obviously make up your own mind. Okay. We are very fortunate to have two very skilled endoscopists. Paul basically lives, sleeps, eats, everything is about endoscopy. I don't think he dreams about anything other than endoscopy as well. Sorry, Janet. And he is an excellent teacher. One of the best colonoscopists I have come across anywhere, and I've seen the best in the world, from US to India to England to anywhere, and I would rate him right up there with anybody else. So we are really, really fortunate. This is his 5th trip here. He's become like a family member now. So I don't even like to introduce him as international faculty. He's more of our national faculty. The same I can say about Waqar, who is again a very accomplished endoscopist, a very good patient teachers you have here, who are here to teach. And they have taken the trouble of coming all the way from there. So it's a very good opportunity for all of you. We want this to be in a very friendly atmosphere. None of us are professors. So we are very ordinary, simple doctors who like to do endoscopy. So there is no, there should be no apprehension if you want to ask something. There's never a question which you can say, you can never call a question silly. Sometimes you learn much more from silly questions than smart questions. So whatever you want to ask, please feel free to interact. This is supposed to be an interactive workshop. We want you to give us a feedback. The more you get active, the more you get out of us. So I think that was important. The difference between this course and the last two courses is this time we have, we normally, in the last course we had 2 live links from UK. But in this particular course, thanks to Paul, again, we have 4 very interesting links. Stephen Foley from Mansfield, who is the medical director there, is going to tell us about endoscopy service delivery in UK and how it's coming up. So we have an idea about what's happening in the developed world. We have Brian McCaig, who leads the colonoscopy training program in UK. So he's responsible for the entire training thing, and he's going to tell us endoscopy training and developments in UK. We have 2 extra, these 2 were standard lectures that we had even in the last courses, but we have 2 interesting lectures. One, polypectomy techniques by Saeed Dean, and bowel cancer screening versus standard by Lorraine Clark. So I think these 4 talks are going to give you an insight to some of the technical experts and how it's done in UK, and obviously how the endoscopy system is structured in UK, how is it monitored and what's happening. So it just gives you an insight so that as we grow, inshallah, and you grow in your field, you can apply some of those, if not all. Because we have Janet here. Janet is Paul's better half. We are very thankful, Janet, for you to allow Paul to come here. A lot of spouses overseas put their foot down and don't allow their hubbies to come here, and I don't blame them, but I'm very grateful, and we are all very thankful for you to not only be here yourself, but also allow Paul. So with that, And we will have some announcements about some housekeeping announcements. We have course dinner tonight instead of tomorrow because Professor Said Qureshi will not be here tomorrow, and so Waqar is also committed somewhere tomorrow, so we shifted it to today so that everybody would be there. We'll tell you in due course as we move forward. So and now, yeah, what we do is we have introduced ourselves, Dr. Sajda Qureshi and Dr. Shahryar. These are the two who have organized the course. Saeed and I get the name, but these are the two people who are behind all the effort that you will see. There's a lot of effort. We have about 25 colonoscopies, Sajda? 25 colonoscopies that we have to do in the next 3 days. So we are hoping that all of the hands-on people will get 5 colonoscopies. 4 is our target, 5 is bonus. So we are hoping that we will give you the bonus. Inshallah, we did last time. We're hoping this time also we'll do that. There's a lot of hard work that goes in, Sajda and Shahryar will run the whole thing for us. Dr. Ali Taj and Dr. Zubair and others in the department obviously support them. I have to say this in the very beginning that we are very grateful to Getz Pharma because Getz Pharma has solely sponsored this entire event, and not only this, but they have actually committed to sponsor all our 3 courses a year, and it's very commendable because they have no interest in endoscopy services at all. They are a standard pharmaceutical company, so this is a very good CSR, and I'm again thankful. So without any further delay, if I can ask the hands-on people to just introduce themselves, unit they come from, city, name, city, unit they come from, and how many colonoscopies have you done independently, if at all?
Bismillahirrahmanirrahim. Dr. Abdul Kafi from Fatima Memorial Hospital, Lahore, and gastroenterology department, and we have just conducted supervised colonoscopies, not independently.
Okay, but you're doing supervised.
Yeah.
How did you find out about our course?
Well, sir, every time you conduct a course, one of our colleagues, they come.
So it's from your colleagues.
So yeah.
And what kind of feedback you
We
got
have got
about?
a very good
I don't want the
feedback.
praise. I want to know whether they benefited after attending the course.
Of course, they have benefited a lot. So, seeing the result of the attending the course, our supervisors decided to send, if possible, every time one trainee, one colleague.
Okay.
Yeah.
You're from Lahore,
Yeah,
Arif.
yeah.
Dr. Dilip Kumar from JPMC Ward 2. We are doing sigmoidoscopies, but we are still in training.
Your boss tells me you do colonoscopies.
Colonoscopy,
So I'm going to be picking up on you. I'm telling you beforehand.
I was observer in.
Shamim Qureshi, who heads their unit, is my class fellow. Pain in the right, left, wherever you want to call it. And we love each other and love to irritate each other as well. He's doing good work in colorectal surgery, and so he was very keen that his people, were working in the ward. So great. Okay.
Sir, I am Dr. Abdul Qadir Khan. You already knows me from Mirpur Khasin. I have done FCPS in medicine and then MSc in gastroenterology, 1-year course under Dr. Sadiq Mehman. I also observed endoscopies in Khan University under Dr. Wasim Jafri. I am doing sigmoidoscopies, not colonoscopies, and upper GI endoscopy as well. I heard about this course in Philippines when I was in the workshop of gastroenterology from Dr. Shahryar Shamshad, who was from Peshawar. He told me about the course. He is FCPS in gastroenterology.
Yeah.
So
You
I
can't-
heard, I always fond of these types of the courses.
Dr. Shahabuddin, FCPS Part 2 training in gastroenterology at Isra University Hospital, Hyderabad. I haven't done independently, but under supervision of my supervisor.
I'm Dr. Farooq Khan from MH Hospital, Rawalpindi. I do independently endoscopies, colonoscopies. I have done 100 plus colonoscopies independently. So this time I came here to see how to work with the international people and as well as with our good
MH,
gastroenterologist,
who is in
Brigadier Amjad Salamat sir.
Amjad Salamat?
Yes.
Okay. Amjad Sahab is back in Pindi?
Yes, now I think for the last 1 month he is back because Brigadier Raja Samiullah is retired now.
Okay.
So he came back.
Well, I'm very happy. That's probably the best thing that's happened to MH.
Yes.
Good. Great. So those are the 5 hands-on. So we move on to the 5 observers, please. Before you start, let me clarify one thing. Observers is something that's not part of the course in UK. In UK, they have 4 people. Yeah, there are 4 candidates. We made it 5. Although we give the same number of colonoscopies as UK, or maybe more, they give 4.
You aim to give 5, maximum of
4 for UK. So we are trying to do more with one more candidate. But what happened was initially we had a lot of requests, and so it was very difficult. So we thought, that because I attended and I've been part of this course, and we all thought that, just sitting here and seeing these guys do and some of the things with the dummies and all, you get very good concepts. You may not get hands-on, so we decided that we'll create this observer thing because there was a lot of pressure to start with. And then, the observers can decide whether they want to come back next year for hands-on or not. But we cannot guarantee, we allow you to have some hands-on on dummies, but obviously nothing more. And that also is not something that we are obliged to do. We like to do that, but depending on how the course goes. But I think there is still a lot of learning. So, with you.
Assalamu alaikum. I'm Dr. Maria Anwar from Surgical Ward 2 JPMC again.
Okay.
And after fellowship, all the fellows that were in our ward were pushed into the endoscopy suites.
Pushed.
Yes, we were pushed to go there. And now that still we are doing flexible sigmoidoscopies, but we have not done any independent colonoscopies.
Okay. Great.
I'm Dr. Naeem from the same from the Surgical Ward 2 JPMC, and again we are seeing Dr. Dilip doing under supervision, so we are observing him over there.
Who's supervising you, Shamim?
Sometime Dr. Shamim, sometime Dr. Shamim sometime came to supervise him.
So, Shamim.
I am Dr. Basir from Liaquat National Hospital. I'm a gastro fellow there, and I'm able to do colonoscopies under supervision, but here I'm here to learn more regarding the technique. So thank you.
So who are you with, Mansoor, or are you linked with one consultant there, or you're with everybody?
No, we are linked with only one consultant.
Who are you with?
I'm with Dr. Shahid Kareem nowadays.
Shahid.
Okay. Thank you.
Assalamualaikum. My name is Dr. Musarrat Tabasi from Isra University Hospital. I am FCPS 2 trainee in gastroenterology department. I can do in colonoscopy, but wherever I feel hindrance or not go beyond the transfers and sometimes descending colon, then Dr. Amir Saab supervised me. Amir Gori, yes.
Isra in Hyderabad is providing very good services to sort of, it's about 2 hours from where we are. And I think they've done a great job. They've got 3 gastroenterologists. Amir, Sadiq, and there's one more. No?
Dr. Ali Akbar.
Ali Akbar Siddiqui. So Ali Akbar has come here for the course. He for the ERCP as well as for the gastro. Dr. Nan just passed. Okay, good.
I am Dr. Badr Jahan from the Liari General Hospital. We are doing the endoscopy. We have this endoscopy suit there and we have the scope there for the colonoscopy, but we don't have any trained person there. We have to send the patient to the civil hospital or the National hospital and our university. So I want to learn it to start this there.
Okay, good. But you are in the surgical unit?
Yes, I am PS in surgery.
Who is the surgeon there?
Dr. Shoaib Gangat was there, but he is not trained in colonoscopy.
And who else is there?
Dr.
Is there a Dr. Aftab Lagari
yes,
there?
yes, he is there.
He has learned all his endoscopy.
He is starting there, but I want to supplement him as well. He is the lone person.
But he should be able to do.
Yes, he is
does
doing.
independent.
He is doing, but sometimes he also faces the difficulties. So to supplement him, I want to learn this one.
Okay, fantastic. So you all have a unit to go back to. That's the most important thing. They can go back and you can practice what you learn here. So, what's the time? Perfect. Huh? Yep. So, without any further delay, you want me to call Vakar? Dr. Vakar is going to tell us the reasons why we should and the reasons why we should not do colonoscopy.
Thanks for your kind introduction. Assalamu alaikum. It's my great pleasure to be here for the 5th hands-on colonoscopy course. In fact, it took us a long time to get it off the ground, but once, alhamdulillah, it's off the ground, it's been going from strength to strength. I'll start off with the boring bits, the indications, contraindications, the consent process, and one minute. The other thing is it's an interactive workshop, so please feel free to chip in whenever you feel, you have a different approach to things, or, you want to question or anything. Don't feel shy about it. We're just trying to find the file. Colonoscopy. Right, okay, so this right. The learning objectives for this course, what we expect you to go back with. And the first one, I'll go through the simple basics, which is the boring bit. The fun part will start with, Paul. He'll start off with a practical, and then we'll hopefully do a few hands-on procedures today. First of all, the process of consent. Then important thing is about the indication and contraindications for colonoscopy, because you don't want to do the procedure in the wrong patient for the wrong cause, and you don't want to miss it, the procedure, when it's really needed. The sedation practice, because we have to be aware of the safety in sedation, and diathermy, I'll touch on it, but we'll discuss that at a later stage, because this is very important, and this is something which, we'll go through it more practically once you've had the bit of a grasp of the subject. But I'll just touch on the theoretical bit, right? So the consent process, before you carry out any procedure, you have to take a consent from the patient, because if you approach a patient without consent or a valid consent, then that's termed as assault. Right now, what is an informed consent? Because when you are consenting a patient, you have to inform the patient about the procedure, what it involves, what are the risks involved in the procedure, what are the benefits of the procedure, and whether they can withdraw consent during the colonoscopy once they've committed themselves to the procedure, whether they are still entitled to withdraw or not, and how to go about it. So the important thing is the informed consent. What we can do about main principles of an informed consent are that the patient has sufficient information about the procedure, its benefits, and the harms it can cause. The other important thing to remember is that when you are carrying out the consent or the consent process, the piece of paper which the patient signs does not have much of a legal value. You might as well tear it apart. The important thing is it's a dynamic process. The moment from your first encounter with the patient till you actually perform the procedure, all the information that is, exchanged with the patient, the discussions that take place, the information that you give to the patient about the procedure, if it is documented in your notes, even if you do not have the actual consent paper, that is a valid legal document. Because once the patient has decided to come for the procedure, he is committed. That means that he has agreed in principle. So the whole process of consent, that's why this discussion, information, informing the patient should be a robust process. So even if you don't have the signed paper, as long as you've got everything documented, he has been legally consented. Informed consent is that the patient is able to understand, retain, use or weigh up the information given to make the decision. That he is able to understand what you are telling him. It's in the right language. He's able to understand that it doesn't, it's not a valid consent that if a patient cannot understand English and give him all the risks and benefits in English, you have to make sure that he understands. Also make sure that he's able to assess the information himself or herself, and then make a decision and communicate their wishes. So, in other words, according to the English law, they have mental capacity. So, you cannot get a valid consent from a patient who's sedated or who's demented or who's acutely confused. That does not hold. So, also you have to make sure that the patient is not under duress or forced into a decision. Consent process should not ideally take place in the endoscopy room. It should be done away from the place of endoscopy, so that the patient has got, is on a neutral territory, is able to refuse and cannot be blackmailed or forced into taking the. Also, it is equally important that you should give the patient alternatives, what other procedures they can undergo. If they are not keen on having a colonoscopy, if they are too scared of it, if they think taking the bowel prep is one hell of a torture, then they should be able to have facilities, where they can have, the same investigation or similar information obtained. And like, in colonoscopy, they can't have a colonoscopy, they can have a barium enema carried out, or they can have a CT colonography done. You have to inform them that it might be as good as a colonoscopy, but it is about 80 or 90% as good. So you have to give them the alternative, so they can pick and choose. You don't have to tell them what is in their best interest. It is their autonomy, their right to make the decision. And they can refuse the treatment or withdraw their consent at any time. And the thing about withdrawal of consent is that even if it is in their best interest, they still have a right to withdraw. You can't force them. Right? Now, in the consent process, if you follow one of these acronyms, follow the structure format of EMBRACE, which I usually show to people, then you can't go wrong. I mean, you've got some sort of a system in your mind. So if you follow that, then it's a good safety net that you don't miss out on any of the things. So you have to make sure that you've given all the information. Always ensure that they've got IV access in case anything happens during the procedure, right? So the EMBRACE acronym for consent is, E stands for explanation of the procedure. So explanation is, you tell them basically what a colonoscopy involves. That you take a flexible tube, take it up the back passage, examine the bowel all the way around. Ideally, you should not use medical jargon. You try to use as simple a language as possible so that the patient can understand what you are talking about. Also, the motive or reason behind it. If somebody's got iron deficiency anemia, you want to tell them why you want to do a colonoscopy, to make sure that you find the source of bleeding, you do not miss a cancer or a polyp or something important, right? So the motive or reasoning behind the medical recommendation. The benefits, why do you want to do it? Because if somebody's got iron deficiency anemia, you can find the cause of it. If you may be able to take a polyp out, or if it's cancer, they can have an operation carried out, or if it's inflammatory bowel disease, they can have the recommended treatment for it. The risks involved, every procedure that you do has got a certain degree of risk involved. And if you explain the risk to the patient and they agree to undergo the procedure in spite of the risk, then you are okay. Even if you have a complication, it occurs, then that is a well-recognized complication. Like if you end up with a perforation and you've taken all the precautions, then that is a recognized procedure, complication which the patient had agreed to undergo. Alternatives, well, it can be doing nothing, or can, if I see a patient who's 95-year-old, is wheelchair bed bound, not able to care for himself or herself, and a GP refers him to me for investigation of iron deficiency anemia, I'm not going to jump up, pick up my scope and colonoscope him or gastroscope him. The first thing that will come to my mind is whether the procedure I'm carrying out, is it going to change the outcome? Even if I find a big cancer there in a 95-year-old bed-bound, wheelchair-bound person, no surgeon in his right state of mind is going to touch him. So even if we find anything there, is it worth putting him through all the stress of a colonoscopy? And normally, most of the time, I just turn it down, or tell the patient, or usually give them the choice, and they would turn it down if I don't turn it. So the thing is, you have to look at the patient as a whole, not just focus on one or two things that, well, it's iron deficiency anemia, you have to do the procedure, right? So, right. Complications. Complications, basically, risk complications come under the same sort of category. So, side effects are, it's just to complete the EMBRACE acronym, basically. So, side effects is, yeah, go on, Paul. Yeah.
Just briefly about
Yeah.
mispathology.
Yes, yeah.
That's a very big thing now in the UK.
Yeah.
So, can I just ask the people how
accurate do you think that a colonoscopy is, even if done by the most experts in the UK or around the world? So what is the percentage accuracy do they estimate a colonoscopy is? So about missing a cancer. Yeah, so what is the chance of missing a cancer?
2.5 years that I have been training, maybe 1 or 2. Yeah.
It must be very good.
Anybody else?
You are asking about the
The chance of missing cancer or missing the polyp?
yeah, maybe 10 to 15%.
The actual UK figure is that they say that it's about 95-96% accurate, so we have a mispathology rate of about 4 to 5%. Currently in the UK there is a thing that's coming in now called the FIT trial, and the FIT test is that people who've had a colonoscopy in 3 years ago will be recalled for another colonoscopy, and then they are looking at those patients and seeing how many people in that group have got a polyp now or got a cancer. And even with the bowel cancer screening, which we'll talk about later, they're finding that it is only 96% accurate. So mispathology, which is what Vakar touched on very early on in this thing, and he will go on about it, is the biggest thing that you need to really be hammering home to patients, and that's something that you mustn't forget.
We'll cover that anyway. Because in US a few years ago, quite a few years ago, when there was not such a great awareness about the skill techniques and your expertise in picking up adenomas, when they did back-to-back studies on colonoscopies, like they would perform a colonoscopy, come out, and another operator would go in and then check. At that time, the mispathology was 10 to 15%. It was quite high. So then, people look back at the practice. Now, what risk do you quote for colonoscopy? So when you are telling the patient about what risk do we cover? So they can, if the patient asks you, can I die from the procedure? The answer is yes, but it's very unlikely. It's very rare, Death can occur. It has occurred in patients, but there are certain circumstances to it. And one of the things you need to make sure is that you select your patients correctly. You don't do it for the wrong reason, and you don't do it in the wrong patient, right? The one that we normally talk about is perforation. Generally speaking, perforation risk is about 1 in 1,000. So, these are different studies that we've quoted, but if you want to give a round figure, then it is 1 in 1,000 in a general diagnostic or an unselected group of patients that you do a colonoscopy, whether you do polypectomies or not. If you concentrate on therapeutic procedures where you do polypectomies, you do dilatations, you do stenting, then the risk of perforation is about 1 in 500. So it doubles up. And the risks are much higher if you are dealing with big polyps, if you are dealing with flat polyps or adenomas, where you have to perform an EMR or ESD. So the risk of perforation is much, much higher than in that. Significant hemorrhage. Generally, when you quote, there are different studies which have been quoted. The average risk of hemorrhage is about 1 in 500, which is just across the board. However, if you are then selecting out your patients, if you are talking about polypectomies or if you are talking about big polyps, then the risk of hemorrhage is significantly higher, 1 in 250 or 1 in 100, especially if you are taking out big polyps with thick pedicles or extensive laterally spreading tumors. Now, if you and it depends on what procedure you do. If you take biopsies, forceps biopsies from a patient's colon or stomach, the risk is negligible, even if the patient is on warfarin or antiplatelet agents. Normally, I don't even bother, some of my colleagues still don't take biopsies, but I do. Unless the patient has come up with a GI hemorrhage, in those cases, I tend not to take biopsies because, it is silly. Polypectomy, now if the patient is on antiplatelet agents or then are anticoagulants, then if you are performing a polypectomy, you ask them to stop their anticoagulants 5 days before the procedure. If they are on aspirin, it doesn't make much difference. Some people do ask them to stop it, but if they are on combination of aspirin or clopidogrel, then you ask them to stop both of them a week before the procedure, or at least the clopidogrel. If they are on clopidogrel, you ask them to stop the clopidogrel because that can increase your risk of hemorrhage. What about the patient who withdraws consent during the middle of the procedure? You are doing a colonoscopy, he finds it very painful, and he says, "Doctor, stop." And what should you do? Completely entitled to refuse the procedure. It's not, your responsibility. So if they want to stop, you have to then consider the option. If the patient is unsedated, then you just stop, because there's no question. They are clear in their mind, they don't want the procedure, and that's it. If they are sedated, then you have to take action in the best interest of the patient. And that involves that you pause. If the patient is distended with air, because most of the time if it's a difficult procedure, we inadvertently put a lot of air in, so suck out all the air that you think you can suck out. You resolve any loops that you might have caused, change the patient position if it's needed, give them extra sedation, and then try again. And if it works, then fine. If it doesn't, then stop. During consent, the do's and don'ts, always make sure that you have read the patient's notes, you know exactly what indication they've come for, because it depends on the indication for the procedure, what you do during the procedure. Always good idea to introduce yourself to the patient, not go as the boss person. Use a structured approach to consent, like we discussed, embrace acronym, make sure that the patient has understood what the procedure is going to involve, and always give them time to ask questions, not just give them a lecture and walk out. Yes, you just ask them कि आपको बात समझ आई है मेरी, और आपने और कुछ पूछना है, ये आपको पता क्या? नहीं, feedback ये कि you use your common sense. मतलब you should, from the conversation understand. Sometimes when you are talking to a patient, you feel it as if you are talking to a wall. So it shouldn't be like that. ठीक है? And if he doesn't understand your language, try to get an interpreter. Don't forget to ensure privacy. Don't do it in a public place, of course. Don't use medical jargon. Don't forget to keep an eye on how long the consent. Now, the talk I did is obviously it took a long time. But when you are actually taking the consent process, then it should not take more than 5 minutes. And if you are doing it for the first time, then it will take half an hour. But if you do it regularly on a structured basis, then you get better at it and you can do it in 5 minutes. So if you do make it a habit of doing it in a structured way, then it shouldn't take you long. Okay. Right. Now, important, what conditions would you do colonoscopy for? What are the indications? Because a lot of the time, colonoscopy is done for the wrong reason. Abdominal pain is not an indication for colonoscopy, because the yield from abdominal pain, for doing colonoscopy for abdominal pain is very low. However, if there are other associated symptoms with abdominal pain, then there may be an indication for colonoscopy, because some conditions like Crohn's disease present with abdominal pain rather than diarrhea. So you have to look at the whole aspect of the patient, right? So just for a vague abdominal pain, it's not the ideal examination. So the indications for colonoscopy that we understand are, that is what is recommended by BSG, which is the British Society of Gastroenterology, are rectal bleeding. Whenever there is rectal bleeding, that always has to be, or bleeding from any orifice, it always has to be investigated, because you want to find the site of the bleeding and so that you can stop it, right? Iron deficiency anemia. Every patient with iron deficiency anemia must have a full investigation, which includes, what else? Yes, and what, during upper GI endoscopy, if it is normal, what else do you do? If you are a good boy, you take a duodenal biopsy to exclude celiac disease, okay? So that should be the approach to patients with iron deficiency anemia. It is not enough to put them on iron tablets, because, okay, if I am being horrible and I tell you, look, mate, you've only got one procedure to do, we can't let you do two because it's, too much of a hassle. Which procedure would you choose to do? Why? Why, if the patient is 35-year-old, then irrespective of the age or whatever, statistically, chances of finding a pathology on colonoscopy is higher. Secondly, if you find a pathology on colonoscopy, there's a higher chance that you can cure it. Because if you look at upper GI cancers, esophageal or gastric, by the time you make a diagnosis, only 10% of our patients go for surgical resection, curative resection. In colonoscopy, it's the other way around. Majority of your patient, you can achieve a curative resection if it's Dukes A or B. And even, with advanced cancer, with liver mets, you can still get some sort of increased survival. So colonoscopy is very important in iron deficiency anemia. So do not ignore iron deficiency anemia. It is not always due to worms. It is not always due to bad diet. You take a good history anyway, but still. Any suspicious appearances on a barium enema or a CT scan, whether it's a CT colonography or a plain CT scan, if the radiologist or if you find a lesion on the CT scan or anything suspicious on barium enema, you are obliged to do a colonoscopy. And in cases of inflammatory bowel disease, assessment of Crohn's disease or ulcerative colitis. And there are 3 indications where you would do colonoscopy in inflammatory bowel disease. Number 1, extent of the disease. Number 2, activity. And then as part of surveillance. Extent, if somebody comes to you with history of bloody diarrhea, all you need to do is to make a diagnosis is to do a rigid sigmoidoscopy. You can do that in your outpatient clinic, 2 minutes job, and you can make a diagnosis of ulcerative colitis. If it is Crohn's disease, you can't make a diagnosis of that. But a lot of the time, I still regularly do it in my clinic. I always have a rigid sigmoidoscope. So if you can make a diagnosis, you don't have to do a colonoscopy there and then, or in the next few weeks. Because if it's a fulminant colitis they've got, colonoscopy is contraindicated. But the important thing is that you can, irrespective of how extensive it is, you can start the treatment immediately. Start them on steroids or the 5-SA preparation. Activity, if the patient with ulcerative colitis keeps coming with diarrhea, being unwell, sometimes the symptoms could well be due to irritable bowel syndrome rather than actual flare-up of his colitis. So in that case, it's a good idea to do a colonoscopy or flexible sigmoidoscopy. And surveillance, if the patient has had ulcerative colitis or Crohn's disease for over 10 years, then they are at increased risk of developing colorectal cancer. In that case, they should have colonoscopy carried out every 3 years, and then if they've had it for 20 years, then every 2 years or 1 year, depending on the other comorbidities, right? So that was, then any unexplained diarrhea, change of bowel habit to looser or more frequent stools lasting more than 6 weeks. You may get diarrheal illness infection for 1 or 2 weeks, which is usually self-limiting, but if it persists and can last for up to 6 weeks, then in that case a colonoscopy is indicated, because change in bowel habits can be indicative of a growth in the bowel, right? Any change in bowel habit in a patient over 60 years of age must always be, whether it is short-term or long-term, must always be investigated by a colonoscopy. Or if the patient is even less than 40 years of age with rectal bleeding, then it must be investigated. Now generally in GI symptoms, if the patient becomes symptomatic, like with dyspepsia or lower GI symptoms, if the patient is below 40 or 45 years of age, you do not straight away do investigation unless there are other alarm symptoms. And alarm symptoms are what? Yeah. Yeah. Fever is not an alarm symptom. Okay. Weight loss, bleeding from any orifice, altered bowel habits is not an alarm symptom, but it is a symptom. It is mainly weight loss, unexplained weight loss, bleeding from any orifice, symptom of dysphagia for upper GI, any palpable mass. So those are alarm symptoms, right? For indication for colonoscopy for screening purposes, like in most of the countries there are national bowel screening programs. So in UK there is the English bowel screening program, the Welsh bowel screening, and the Scottish. Similarly in US there are bowel cancer screening programs. So in those cases they would do according to their protocols. Family history of polyposis syndrome or colorectal cancer. Surveillance, you do surveillance in certain groups of patients, and those who have had previous polyps or cancers resected would require surveillance according to the polyp size and numbers. Patients with inflammatory bowel disease, as we just discussed, patients who have had ureterosigmoidostomy, they are at increased risk of developing colorectal cancer, so they need. Patients with acromegaly, because of high levels of growth hormones, they are at increased risk of developing colorectal cancer, right? So those patients should have regular surveillance colonoscopies. Contraindications to colonoscopy, very important. Withdrawal of consent by a competent patient is a contraindication to do a colonoscopy, because if you carry on doing a colonoscopy, that is an assault. So that should stop. Endoscopist who's not accredited or incompetent to perform the procedure should not do it independently. They should be trained to do a procedure, because it can be lethal in untrained hands, right? Uncooperative patient, if you cannot sedate the patient or the patient is not cooperative, stop, because you might do more harm than good. So that is contraindication. Most of the contraindications are relative, but some of them are absolute. Acute severe colitis, do not attempt a colonoscopy during it. You can do a flexible sigmoidoscopy with limited bowel prep, but don't do a full colonoscopy, because the bowel is very fragile, it's very frail, and you might perforate it easily or cause toxic dilatation. So we do not do acute colonoscopy in acute severe colitis. Anyone with toxic megacolon, don't touch them. Acute diverticulitis, again, you are at risk of causing a perforation. Acute abdomen, if the surgeons try to force you to do a colonoscopy, don't do it, because the treatment for acute abdomen is a laparotomy, not colonoscopy. or the investigation of choice is CT scan, not colonoscopy, right? So don't do that. Perforated viscous, again, never even dream of doing it. A lot of the because if you look at colonoscopy, there are certain things that are involved in it. The bowel prep, sedation, and the procedure itself. So you have to see whether your patient is fit for a bowel prep, like the 95-year-old person who is bed-bound, chair-bound, you can't take bowel prep for you. Sedation, if somebody has got severe chronic obstructive airways disease, you give him a bit of midazolam or pethidine and they stop breathing, right? The procedure and therapy himself, whether they can undergo the procedure or not, right? The whole thing about it, whether they are strong enough to do it. So they are related to a condition that the patient might have. Now, coming to complications of colonoscopy, what happens? The one that we most dread is perforation during, the procedure. During diagnostic colonoscopy, perforation is extremely, extremely rare. Nobody should get it. Because if you are doing it properly, the colon is normal, healthy, you shouldn't perforate. If you've perforated it, you've done it wrongly, basically. You've been too rough, right? The perforations that usually occur are the ones that occur when we carry out therapeutic procedures like polypectomies, dilatations, stenting, right? Or it can occur when there's a weakness in the bowel wall like diverticular disease and severe colitis. So those are contraindications to doing colonoscopies. If there is active diverticulitis, you can do colonoscopy in diverticular disease, there's no contraindication to that. If you get a perforation, the first thing is don't hide it. Don't try to cover up and send the patient home. Even if you suspect it is perforation, keep the patient in hospital, don't send them home. It might turn out to be that there was just too much distension in the air and not perforation, so still, it's better to be safe than sorry, yeah? After perforation, what happens, the factors that are associated with poor outcome, increasing age, the more the patient is elderly, of a higher age, the risk of causing harm is more. They do poorly on perforation. Significant comorbidities, they've got heart disease, chest problems, they are going to do badly. They will do badly if they undergo laparotomy to repair the perforation. Delayed recognition of perforation, that's very important. Always have a high index of suspicion if the patient is symptomatic after a procedure. Delayed treatment, poor bowel prep because of peritoneal soiling. Bleeding, there is approximately 1% risk of post-polypectomy bleeding, so 1 in 100 cases can get it. And normally, if there is, you take a polyp out, it starts spurting in your face, then that's easy. You can treat it there and then. Sometimes you can get delayed bleeding. If there is bleeding, don't just take the colonoscope out, wait till it's settled. Because if you try to then do it later, and as soon as you see bleeding, because whenever I do polypectomy, I do not take the snare out immediately. We wait. Because sometimes if it starts bleeding, you can still catch it with the snare, the stump, and treat it. Or just use tamponade on it, pull the snare in tight, and it just holds it, and then you can treat it, or clip it. Because if you delay it too much, then there may be so much blood that your visibility is lost. So those moments are very precious for you to give treatment. Because we all get bleeding from time to time, there's no problem, but you can treat it. Most of the time, in the last few years, I've hardly sent anyone for surgery to stop bleeding. We do it endoscopically. Delayed bleeding. Bleeding can occur up to several days, from 1 to 10 days after the procedure. So don't be surprised. But the important thing is, tell the patient that if you see blood, please come back immediately to the hospital. Because the moment they start bleeding, it's better that they are in rather than out. Now, if it's a big polyp, there's a higher risk of bleeding. If it's in difficult to access position, then it's also, higher risk, because even if you take the polyp out and it starts bleeding, you may have difficulty in getting to it. So always carry out procedures that are within your field of expertise. If you are a lightweight boxer, you do not want to fight with a heavyweight boxer. You always do whatever is within your ability. So if a polyp is big, don't touch it yourself. If you have not been trained to take big polyps out, send it to somebody who is more of an expert. And if you are carrying out any of these major therapeutic procedures, make sure that you've got all the other, accessories to stop the bleeding, like with hemoclips, you've got loops, APC, everything there. Now, procedure colonoscopy, before you carry out colonoscopy, you have to give them bowel prep. Bowel prep, we use various types. In UK, the one that we commonly use is stuff called movie prep. It's polyethylene glycol, and it just causes osmotic diarrhea. And it's very effective. We used to use Picolex in the past, but hardly ever use it now. Bowel prep, a lot of it can cause electrolyte imbalance. Can I request you to put your mobiles on silence? I think it is outside, but just put on silent mode. It can cause electrolyte imbalances, and you have to be conscious of that in patients with heart disease and kidney disease, right? So if somebody's got chronic kidney disease or congestive heart failure, you have to be conscious of that. So the effect, it can cause hypovolemia, and especially in elderly patients, that can be quite deleterious, because it can cause hypotension and falls. It can cause hyponatremia, it can cause hypokalemia, hypocalcemia, and especially with Picolex, it can cause hyperphosphatemia in patients with kidney disease. So frail patients may develop postural hypotension and increase the risk of falling. So to minimize these side effects, bowel preparation should be prescribed by a clinician who can assess each patient individually and who knows what he's prescribing. So you should know the effects of it. So the large volume non-absorbed isosmotic agent like clean prep, movie prep are less likely caused. So most of these are quite safe in patients with kidney disease and heart. So those are the ones that we normally routinely prescribe anyway. The problem with them is compliance, because they've got a very sort of salty taste. They taste like plastic, and they are horrible to take, and you have to take large volume. For clean prep, you have to take 4 liters of the fluid, and for movie prep, 2 liters of fluid. It's still quite a lot. Now, just what Paul mentioned earlier on, mispathology, very important. Number one, you should mention if the patient as well, that there's a 5% chance that I might miss the procedure. It's not 100% sensitive. And the other thing you need to make sure is that the patient should be told that even after a normal colonoscopy, they should not ignore rectal bleeding. If you do a colonoscopy, it comes back normal, and the patient has rectal bleeding, don't tell him that I've checked you out, everything is fine. You still need to be with it, And they should not, again, subsequent change in bowel habit, they should be reassessed. Right, okay? Always assess your patients, because elderly patients with comorbidity and patients with significant CVS, respiratory, renal, or malignant disease have a higher procedural mortality. Just like any surgeon would not operate on every patient, you have to assess them. So our assessment criteria are a bit more liberal, but still you need to make sure that you don't have deaths on the table. And so if the patient have got fulminant colitis or other comorbid conditions, then be careful, or refer to somebody who's more experienced. Now, patients who have undergone previous abdominal surgery, in women, especially if they're post-hysterectomy, colonoscopy is very challenging. Even I find it difficult, and I do thousands of them. So always be careful in those patients. Patients who have got extensive diverticular disease, colonoscopy can be challenging. So because they've got tethering, adhesions, everything. Previous laparotomies cause adhesions and fixed angulation of the bowel. So colonoscopy can be challenging. So always be careful. If they are on anticoagulants, they've got bleeding disorder like hemophilia, Bleeding, any other bleeding disorder, you should get opinions from hematologists. If they are on anticoagulants, you ask them to stop the anticoagulants because 5 days before the procedure. If they've got allergy to sedatives, then that should be taken note of. So, and if there are other factors which can put the patient at risk, then consider, because in a lot of my frail patients, I tend to do CT colonography. Oh, you should be aware of it. If you know that they've had previous pelvic and abdominal malignancy, then they would have had radiotherapy or they would have had hysterectomy, then in that case you should be aware of it and you should let a more experienced person do it. That's how you do it. You can't prevent yeah. Pardon? Adhesions. Again, adhesions will cause tethering of the bowel, fixed angulation. So it cannot be done by a beginner or it should be done by, so in these cases you ask a more experienced, you start the day before the procedure. So if they are having it tomorrow morning, you start 1 p.m. today, right? The movie prep comes in 2 sachets, 2 packets, and that's how it comes with instructions. So the patient puts it in, dissolves it in 2 liters of water, the whole thing, and then drinks it. I don't know, it depends on the brand that is available here. They would have their own instructions with them. So we usually follow that. There is, we normally, I can't tell you exactly, but normally we have a fixed package that comes for a colonoscopy bowel prep. So it comes in a fixed package. I think they use about 16 sachets, 12 sachets or 16 sachets. But actually the same, yes, it depends. I can't give you an answer on that because we use another type of preparation. It's a fixed, you have to actually look at the manufacturer's guidance on that. Right. Any questions about indication, contraindication, consent? No, you know everything about it, so it's now my turn to ask you questions. Anyway, we'll talk about sedation. Very important, because when I started endoscopy, we used to give 20 milligrams of diazepam as a stat dose and knock the patient out and then get on with our endoscopy. Then when midazolam came, we were told to half the dose. So we were giving 10 milligrams of midazolam and knock the patient out and get on with it. And once my elder brother is a consultant anesthetist, and once I mentioned that to him, and he nearly had a fit. Well, how the hell can you use such a big dose and get away with it? And he said that even if you give 1 or 2 milligrams of midazolam, that is more than enough. And I just laughed at him. I said, you have no idea what you're talking about. But over the period of years, and this is one of the beauty of working in developed countries, that everything is audited. Whether it is your colonoscopy practice or whether you are running the government. Unfortunately, here nothing is audited, whether it's running the government or whether it's your medical practice. So we don't know how much harm we are causing. So over there's a department or there's a sort of a process which is called NCPOD, National Confidential Inquiry into Patient Outcome and Death. We are all audited on that. So when they looked at it, their report found that in 2004, not very long ago, 14% of cases had been over-sedated. And I think this is an underestimate. My own feeling is it was a lot more patients were being, and there were certain groups of endoscopists who used to give mega doses, especially our surgical colleagues in our hospital. They used to give mega doses because they are used to patients being totally unresponsive to them. They are used to working on totally anesthetized patients. So they would like to give, total mega dose of sedation. So then they also found out, the British Society of Gastroenterology found out that use of excessive doses of sedative and opiate medication, especially in elderly patients, were associated with a higher mortality. So putting 2 and 2 together, they published their guidelines. And just before we go out anywhere, the risk of complications from sedation. As you all know, it's respiratory depression, aspiration pneumonia, they are very heavily sedated, cardiac arrhythmias because they become hypoxic, so the heart becomes irritable, hypotension, hypertension, angina, MI, you get all these different types of side effects with it, nausea, vomiting, excitation, antegrade memory loss. So, right. What risks relating to sedation should be discussed during the consent process? Now, the other thing is, when patients were being heavily sedated, the patient response would go. So people used to push hard and they would just keep on pushing the colonoscope. Now that is very dangerous because the mesentery is being stretched out and you can cause a tear of the colonic wall or the mesocolon or the transverse colon mesentery. And that's why I never allow any of my trainees to do colonoscopy on generally anesthetized patients. Because some cases, sometimes like in children or some of the uncooperative patients, we have to do general anesthetic to perform a colonoscopy. If that is the case, then I do that myself or one of my other experienced colleagues do it. Because you have to be extremely, extremely cautious. Normally, if they've got conscious sedation and the patient starts crying out with pain or becomes very uncomfortable, you stop. And that is a good sort of a check on you. Because if that check is lost, you might shove the whole scope in and cause a complete tear of their colon. So that's why sedation is so important, that it is only conscious sedation. And you lose less sedation, but you use more skill. Well, as I said, we were using very high doses. Now my average dose for colonoscopy is, a lot of them I do without any sedation or opioids. My average, we audit our dosages, everything, success rate on an annual basis. My average for midazolam is 1.2 milligrams, which includes every group of patients, and for pethidine is about 25 milligrams. So I just use those, and a lot of the patients we just use nothing. We don't use diazepam, we use midazolam, which is dormicom. Midazolam, yeah. So that is, I use 1.1 or 1.2 milligram on an average. Sometimes I mean 2 milligrams, sometimes nothing, but not more than that. Opioids, I use pethidine. Some people use different types, but I use about 25 milligram of pethidine, some at the most 50. So it is very important that you use less sedation, because number one, if you do less sedation, you'll be using more skill. Colonoscopy can be quite a painless procedure if you know how to do it. And most of the stress we'll be doing it on will be torque steering. You just don't keep on shoving the scope. You torque steering and you are reducing, and then reduce loops. So make sure that you do not get any loops in there. It's a nice straight curve, right? So that's the whole thing about colonoscopy, and that's the whole purpose of this course. So try to get that, As Dr. Saad Niaz mentioned, we are not going to make experts or specialists out of you. It takes months to years to do that. You have to practice. There's no substitute for that, right? So sedation risk will be dependent on comorbidity and other patient-related factors. Therefore, you need to assess the patient, medical, surgical, and drug history is essential. So what other medication they are taking, whether they've got heart problems, they've got chest problems, so all those are important. When you are consenting them, for most patients, mentioning risk of respiratory depression and need for monitoring. So you tell them that, look, this can suppress your breathing, this can affect your heart, it can cause nausea, vomiting, and a bit of memory loss, because the patient loses memory for the procedure. That's the whole purpose of it. What agents do we use normally? I mean, it depends on what is available to you. But we normally use midazolam and we use pethidine. Midazolam has a synergistic effect when used in combination with opioids, so you have to be careful with the dose. Whenever we use the two together, we always give the opioid first. So pethidine should be given, or fentanyl, some people use fentanyl, so that should be given before the midazolam, and then you wait for 1 minute, and then you give the midazolam. The other thing is, when you have given the opioid, you always monitor the oxygen saturation, the pulse BP before that. You give the opioid and then you monitor again to make sure that there is no drop. Because if you give the two together, then you've got no control. So if you feel that after giving pethidine or fentanyl, there's a drop in O2 sat, then you might not even need to give the midazolam, right? Well, this is clever stuff, so don't worry too much about that. Patients who are obese, they are elderly with cardiac failure, with renal or liver impairment, use a lower dose of midazolam, as common sense would dictate. Now, most of the patients who require colonoscopies are patients who are in the elderly group. They are above 45, 50 years old. Most of average patient of our age is about 75, 80 that undergo. So in those cases, they've got other problems of, like heart disease or diabetes. So they are at a higher risk. So one has to be cautious. Now, in patients above 70 years of age, our ceiling of midazolam dose is 2 milligram. We never give more than 2 milligram of midazolam in anyone above 70 years of age without airway protection. If they require more, you then shouldn't do it, right? In younger patients, our maximum dose is 5 milligram. But as I said, I hardly ever use more than 2 milligram in those patients. Very, very rare occasion. We leave this bit, don't want any clever stuff. Opioids are given for their analgesic properties. So they can also cause respiratory depression, and the respiratory depression, if they are given in combination with midazolam, can be synergistic. With BSG guidance, the dose of pethidine, again, it should be not more than 50 milligram maximum, that is in younger patients, but if they are above 70 years of age, then it should be not more than 25 milligrams maximum. Pethidine is associated with increased risk of nausea and vomiting, and sometimes it can cause a local reaction. The veins, become sort of red and phlebitic. That is because of local release of bradykinin. Reversal agents we use for flumazenil or Anaxate for midazolam, and Narcan or naloxone for opioids, right? Whenever we use a reversal agent in our practice, that is scored as an adverse incidence. So it has to be entered into the DATEX, which is the adverse incidence database. So it will go against me that I've been a bit rash in my use of sedation. So it's a good sort of scoring system that at the end of the year when my audit comes, it will also show that how many times have I used reversal agents. So that's another deterrent against using high doses. So what is appropriate sedation? Appropriate sedation is also known as conscious sedation. Conscious sedation is drug-induced depression of consciousness during which the patient is a bit drowsy, but when you talk to them, they would respond to you. So they are not, they're totally knocked out. So when you are talking to your patient, they'll respond to you. But if you don't talk to them, then they are all right. So it should be like that. They shouldn't be knocked out, because when they are knocked out, then their airway is not protected. So either alone or accompanied by light tactile, just by touching them, they should be able to respond. So in this case, no interventions are required to maintain a patient's airway. So spontaneous ventilation is adequate. But if the sedation becomes deeper, then they can become. So there's a continuum from desirable anxiolysis and antegrade amnesia to a patient anesthetized with an unprotected airway. You all know that as you increase the dose of your midazolam and opioid, you can transform from conscious sedation to a complete general anesthetic. Because giving high doses of midazolam and pethidine can give you general anesthesia. So you don't want to do that. So the starting dose, whenever you do any procedure, for midazolam it is 1 milligram and for pethidine 25 milligram, even in younger patients. If they need more, you can top it up. So it is better to titrate the dose as you go along rather than give one whoosh. When should reversal agents be used? Whenever there is compromise of their breathing, they should use. Now, a lot of the time, people depend entirely on pulse oximetry, or they are helpful guides. But sometimes it may be too late when you depend on them. As soon as there is loss of verbal contact with the patient, you talk to the patient and they don't respond, that is the time to get worried. So even if their O2 saturation is normal and they are not responding to you, it's an indication that they are oversaturated and you need to do something about it. Managing respiratory depression, if you feel they are oversaturated, then you try to wake them up, stimulate them, give them, a bit of a few shoves. And if they are not responding, then it is better to use the IV through methanol, especially first, and then followed by naloxone. And at the same time, concentrate on protecting the airway. If needed, they might require ET tube or assisted ventilation. And if they are going off, then call the cardiac arrest team before it's too late. What to do then those of sedation? Normally, the standard practice, especially in UK, that whenever we give any injection, we are required to look at, before we break them, we look at the M2, check what the drug name is, the strength of the drug, and the expiry date. Those are mandatory. If you don't do that, you'll fail your assessment exam. So that is done by the nurses and the doctors. So, because at the end of the day, as a doctor, it's your responsibility, the patient goes off. Register all vital signs before giving sedation. Allow adequate time after giving drugs to monitor effect. So, don't give pethidine and midazolam together. Give pethidine first, wait for a minute or two, and then give midazolam. And work as a team with your nursing staff, because if they tell you that the patient is going off or is not responding, you should respond to them. Don't ignore their calls. Do not ignore any alarm bells, because sometimes your pulse oximeter is set to certain level. If the oxygen saturation drop below 90, the alarm goes off. So don't ignore those alarms. Don't work through it. If the patient, the pulse oximeter is giving alarms, stop the procedure and pay attention to the patient. Now, the do's and don'ts. Don't give midazolam before opiates. It's always opiates first. Forget to monitor observations throughout and after the procedure, and alarms. Don't ignore alarms. Do not ignore information given to you by the nursing staff, because they are actually looking at the patient, observing them. And if their pulse, the oxygen saturation drops, don't just switch up the oxygen, the FiO2, or increase the flow of oxygen, because that is giving you a false sense of security. Look at the reason why they are becoming hypoxic. Where are we up to, son?
We're fine.
You're okay.
You wind it up to...
I've almost done. I'll just do a touch on diathermy, but I think diathermy will give more time. I'll just do a bit of the theory behind it, but we'll talk more in detail. We'll discuss diathermy in more detail, because that is something which requires a lot more attention, as it can be quite risky. So what I'll do is I'll just touch on some of the, there are two types of diathermy that we use, broadly speaking: monopolar diathermy and bipolar. Well, obviously, if it's monopolar, the next one is going to be bipolar. In monopolar, the current passes between the endoscope accessory, which is your forceps, hot bath, snare, or one of those things, and between another patient plate which is attached on it. The difference is, if you know the basics of electricity or electrical current, if it is going through a smaller area, it will heat up. If it is going through a larger surface area, it doesn't heat up, right? So the patient plate will not heat up, but the accessory will heat up because it's concentrated in a smaller place, right? So that is what is meant by monopolar, and I'll just show you a little diagram. This is your patient plate, and that is your accessory. The forceps are, snare, and the current will flow that way, but this will heat up, right? In bipolar, the two electrodes are combined at the source, and so it is usually like a gold probe or a heater probe, and current passes through the tissue between the two electrodes. So it's just a tiny space there. and not through the patient's body. So no plate is required in that case. And it is just diagrammatically that one. Now I'll just show you. There's a cut current, coagulation current, and blend current. Cut current is low voltage, low wave current, heats tissue quickly over a small area, minimal tissue damage, but cuts it. Coagulation is a high voltage, high wave current form, heats wider area of tissue more slowly, resulting in deeper tissue damage and sort of cooking of tissue, right? So it causes less bleeding. Well, it's sort of supposed to be hemostatic, and cutting current is cutting but not hemostatic. Normally, we usually combine the two together in various forms. So we'll discuss that. This is an important diagram to remember. If you imagine that this is the cutting wire, immediately next door to it, the tissue literally is desiccated and vaporized because of the high temperature. Then there is, around that at a distance, is coagulated, which is seen as a white blanching of the tissue. And then there is another band of tissue which is very important to know, is what we call devitalized, but it looks normal. And that is important to remember, because sometimes you can get, everything might look normal, but you can get a delayed perforation because of deep burns. The other thing to remember is that the left colon is about 3 millimeters thick, so it's not very thick, if you remember. The right colon is 1.5 millimeters thick, so you have to be very careful in what you do in the right colon. I'll leave these bits out, and so as I mentioned, you can get transmural burns without perforation, and that might present later as a perforation, and I'll just give you a diagram of that. So this is the right colon. Its wall is 1.5 millimeter thick or thin, and if that right colon is distended with air, which it normally would be during colonoscopy, that 1.5 millimeter is then reduced further to 0.5 millimeter, because as you blow up a balloon, it stretches out, and so you are on very thin ice or thin colons, right? 3 millimeter, yes, this is a bit, you got a bit more leeway there, but again, it's not an awful lot. So I think I'll just stop here, because I just wanted to highlight those issues. Diathermy will discuss in more detail about the types of currents that we use and what have you. Right? Thank you very much for your kind attention. Thank you.
Thanks, Waqar. Questions? Whoever was awake.
What is the chances of missing the pathology in CT?
Oh, what are the chances of missing?
About 90, depending on
There are definitely patients if they are not fitted for colonoscopy.
it depends. It's very much operator dependent on software dependent. Currently, it's about 90 to 95% sensitive.
Okay, before that, I think you made a point where the patient is not fit for colonoscopy. Okay, some of the things I would tell you personally, and I'll also have my colleagues comment on it. Number one, if you can't sedate a patient, doesn't mean you can't do a colonoscopy, and that's one thing you're going to learn in this course, hopefully. So that's not being able to sedate is not a contraindication to colonoscopy. You can do a non-sedated, pain-free or minimal pain colonoscopy, and hopefully that's what you're going to learn here. That's number one point. Number 2 point, where you have contraindication to colonoscopy in terms of understanding, consent, you probably will have the same problem with CT scan. There is something that goes up through the back passage even in CT scan, CT colonoscopy. They will not be able to do it without that. So it is about making the patient understand. The CT colonoscopy advantage is basically that it is supposedly a non-invasive modality, although you do invade, and it gives you radiation. I think the role is really more on a screening system, and that's where I think you people can chip in. In our system in Karachi, when did I last refer a patient for CT colonoscopy? I honestly can't remember. And the reason being twofold. It's operator dependent. It's computer program dependent. So I may not get the results that I want. And even if our reasons for colonoscopy quite often are blood in the stool, okay, you're suspecting polyp, you're suspecting malignancy. What are you going to do after CT colonoscopy? You're going to bring the patient back for biopsy or polyp removal or colitis or whatever. So in my own practice, in my own understanding, really the role of CT colonoscopy, and it's not cheap, okay, and it's not easily available. So all those things, you know, in the Western world it's slightly different because they would want to screen and cut down the number of colonoscopies they are doing. They are doing screening colonoscopies. They are trying to pick up cancers or polyps early. So they have huge workload. So they want to somehow or the other, you know, bring down the waiting list so that some patients can go, and those who have got normal CT colon, they don't have to have colon, so they've cut down the numbers that require colonoscopy. I think that's where the real role of CT colonoscopy is, if you both want to chip in anything else.
So small polyps in the UK, 5 millimeter, even down to 3 millimeter with the quality of the equipment. We actually tell them actively, do not report any polyps less than 10 millimeters in size. They clearly have to be that, because the reason they've gone for CT colography is lesion exclusion. And if they've got a cancer, then but why are you requesting the CT in the first place? What are you going to do with the information? Sometimes it's in the best interest to remain ignorant, and that's the difficult scenario we end up in. We in the UK will send someone if we've failed on the colonoscopy, and then because of the accuracy of the reporting machinery that we've got these days, we can then opt straight for surgery and take it as a definitive issue. But if we've asked them deliberately not to report any small polyps less than 10 millimeter, so we don't have to be more proactive.
Yeah, that's an important point. I mean, secondary reason for CT colonoscopy would be if we fail to go past a stricture, which is distal stricture, and you want to see the proximal colon, CT colonoscopy would have a role in that. But that role is different, not the way the indications that you mentioned. It wouldn't have a primary role, and like Paul said, a lot of things that are reported on CT colonoscopy can be misleading as well. Very, very tiny polyps that are picked up.
The other thing is, always remember, whenever you order investigation, you have to think, is it going to change my management? And as I mentioned about the 95-year-old lady who's bed-bound, chair-bound, if they come with iron deficiency anemia, change in bowel habits, I normally wouldn't bother doing any investigation on them, because even if you find a lesion, what the hell are you going to do about it? So whenever you order any investigation, whether it's for colon or for heart or anything, always, you know, ask yourself a question: is this investigation going to change my management? If it's not really worth it.
Not for inflammatory bowel disease. I'm sure
Inflammatory
both
bowel
of my
disease.
colleagues will totally agree with me.
The gold standard for, as I mentioned, if you are talking about ulcerative colitis, you don't need a colonoscopy. You need a rigid sigmoidoscopy. That's it. Yes,
Okay.
for extent of disease, that's different. You can do that, but if you want to treat it, just rigid sigmoidoscopy.
Let me tell you something new. That about inflammatory bowel disease, which you both probably only hear when you come here. We have this concept that when we have ulcerative colitis, diagnosed ulcerative colitis, you've got somebody who's known ulcerative colitis, biopsy proven, you know the extent, everything, and the patient relapses, you don't need a colonoscopy. It's only done here. You have one patient with colitis who would have had 8 colonoscopies. They are being done every year. Even if they are well and stable and they haven't had the 8-10 years pass, they still end up having colonoscopy just to see how things are. You don't need colonoscopy, and I hope both of you agree with me. You only need initial assessment, and then the surveillance starts after a certain period, usually about 8 to 10 years, in patients who've got extensive colitis. Otherwise, you really don't need to. The practice of doing colonoscopy in people who've got inflammatory bowel disease just to evaluate or to see whether this is a relapse or not is totally unnecessary. The disease has this is how the disease is. It relapses. So a relapsing disorder will relapse. And when it relapses, you treat it. You alter your treatment rather than going back and seeing. So firstly, you don't need another colonoscopy unless you're suspecting something else, unless you are not sure of a diagnosis or there is some other reason, specific reason. I fail to understand what it would be in the early years of a patient who's been diagnosed as inflammatory bowel disease. But nevertheless, if you have a query, then that's a different thing. But just to go in and check, which I know most of you have seen. I know this is a practice at AKUH, which is absolutely unproven and unscientific, and troublesome to the patient. Like you said, before that, again going back, a patient with colitis really is one of the easiest colonoscopies. The colon is much more simpler and straighter in patients who've got ulcerative colitis. So the experience she had in colonoscopy at the time of her first colonoscopy is what we are trying to tell you shouldn't happen. Yeah, but it shouldn't happen. I've had my colonoscopy done and it was done without sedation. Right?
Yes.
And do I have a problem having it done again? No. Would I have sedation? No. Would I ever have sedation for colonoscopy or upper GI? I've had my upper GIs 4 times. I've not had sedation even once. And it's an unpleasant procedure. You don't like anything going through your mouth or through the back passage. That's normal, but it should not be painful. Occasional twinge, occasional pain, which the patient doesn't mind, end of the procedure is fine. But for a patient to come and say that I don't want to have a colonoscopy because I've had a bad experience, means she or he did not have appropriate or proper colonoscopy. And we hope that in the next 3 days, that's what we are going to teach you. Most of our patients done in this course, while people are being trained, are done under very minimal sedation. Our sedation, and this is something that will be touched, they are way ahead of us in England and probably ahead of most countries in the world. The amount of sedation they use is very, very little. And the reason is because they know how to do colonoscopy. If you know how to do proper colonoscopy, you won't need this, and you won't have these patients coming and saying, oh my God, never again. So that's the answer to your short question.
Especially from people who are mainly illiterate people. If we just tell them about the perforation or hemorrhage or death, of course they will just refuse because they don't know what percentage means.
Okay, I tell them, generally speaking, and I don't know, to make it simple, I tell them you came from Hyderabad. You came through the motorway, which is a dangerous motorway. There are firing incidences, there is a big chance of tire burst, and you have so many things when you're traveling in the car on a motorway. Why did you come to me? You took this risk. You see it every day in the paper. What is the chance of an individual having it? Very small. The benefit of coming and seeing a physician or to have a procedure, if that outweighs significantly the risks, that's fine. If you are perforating, 1 in 100, there is a problem. Yeah. Okay, and if you're not, then you're okay. So you need to tell them that I tell my patients it's safer to have a colonoscopy or an endoscopy by me than to travel to my clinic. Now they have to make up their mind. So it's, you need to pick up something that they understand. They won't understand 1%. I don't understand what 1%. Yeah. And stats is a group. Stats doesn't tell you about the individual risk. Individual risk is either 0 or 100. You either have perforation, you don't have perforation. Yeah. So what we do is we take a group and we apply it to our patients, but that actually doesn't apply to an individual. That's how I understand it. So I just basically tell them it's, and you have to know how safe you are. So that's how.
Properly prepared. Bowel, his or her bowel is not properly prepared. After how much time we can call again the patient?
Oh, call them again next day if you want to. It's better if you call them the next day. You already have half prep. You're likely to have better prep. So what you can do is you can keep them on clear fluids. Okay, give them another solution. We use phosphate-based solutions here. PEG solution is not available.
Sometimes the patient not come the next day.
Yeah, but you can call them. What I'm trying to say is you can call them next day or whenever you want to. But remember, the next day advantage is that your prep is already half done at least. So if you continue with that, you're likely to get better prep within the next day, if you can do it. If you can't, you call them whenever it's convenient for them, but you need to then sit down and explain to them where you think they haven't actually done properly. Quite often they're not on clear fluids, which I think is important. They eat their last supper or last meal thinking, oh my God, will I ever get a chance to eat or not? This is my last procedure or last day of my life. So before they have it done, I've noticed they come in with solid food and everything else, and that's where the problem is. Sometimes some people are different. I mean, they don't clarify. But what is important is before you start the procedure, you ask them if they had clear watery stools. If they had clear watery stools, you know that you're going to be 9 out of 10 times you're going to have good bowel prep or decent bowel prep. Last question, and then I've been told by Dr. Sajda that we have to stop for tea. I think that's a point that must have been touched by Dr. Vakar. So.
If you feel that there may be too much looping, you can take the loop out, reassure the patient that look, I'm trying to sort it out for you. Give them a bit of a pause. You can consider giving them extra sedation if you want, or extra painkillers, and see if that helps. If a lot of the time, when you do those maneuvers, the patient will relax and you can continue. If the patient is still adamant that no, take it out, then that's it. You can't just have to take it out.
There are 2 points he's made, if you divide it into 2. One, patient is having pain because of your own technique. So you need to assess yourself as to what are you doing. Is your scope too much in? Are you making a loop? Have you put in too much air? Okay. If you're doing any of those, you undo those and see what happens. If the patient becomes comfortable, you know it's you. Okay. So he or she is having pain. Whether he or she is aware of it, once you've given midazolam, even if you've given 1 milligram, you can't be sure. So the point he's making is that it's not about giving 1 milligram or 3 milligram. It's about giving a medicine that causes sedation. If you've given 1 milligram, you've used midazolam, you've sedated the patient. The patient says, after reduction and everything else, still says, I don't want to go through, respect the decision. The other thing is, like he said, if you've given very small dose, you can up the dose, correct your things, up the dose, continue. If the patient's still having pain, don't. You are not going to lose anything by withdrawing, but by continuing, if the patient understands and says no, you're actually doing something that can, well, we're fortunate we don't have much of legal issues here, but that you can end up having. Okay, with that we'll end this session. Tea is served for all of you outside, so if all of you can make your way, have a quick cup of coffee or tea, and then come back and we assemble here in 10 minutes? 10 minutes. So, yeah, 10:30 is 10 minutes.
7 minutes.
Oh, that's about, 10 minutes. We won't be that particular. 3 minutes is okay. Okay. Yeah, 20 minutes. And then it's practically all day tomorrow is hands-on. So the way it works is we have 2 endoscopy suites that are working. And the hands-on people go into one of the rooms and they continue doing one of the room is transmitted here. While those hands-on who are not there can continue practicing on the dummy, and when they are fed up with the dummy and they don't want to use the dummy because they want the real patient, then we allow the observers to come on the dummy and use it. You will get more chance on the day 3 actually, because by day 3 they would all be going and coming into the room. So day 3 again is going to be mostly hands-on. We'll do some micro teaching on day 3. So it's lectures are mainly in the morning. So you're done with the lectures almost. And we'll see. So how much time we have before we connect, or should we start and
Try and speak now. CVs.
try if you want to.
If you'd like to leave a video message.
I'll try him again in a second.
Most of the time alcoholics are
Steve's very punctual. He's a chap who, he says 7, 7. I'll just wait for him.
जो मैं यही बता रहा हूँ ना, हमारे मतलब चाहे फंड पे जाए तो मतलब ये अल्कोहल तो वहाँ पे रेगुलर वो है ना, तो कोई प्रवाह नहीं कम पीछे ज़्यादा पीने वाली
she's talking about
नहीं आया
she's talking about the
it shouldn't go off the thing.
alcoholic section.
It doesn't make any difference, not an awful lot, except जो बहुत ज़्यादा hard drinkers होते हैं, otherwise most
यहाँ पे दो zero या hard. Each one of them. And if there is no, they drink in bottles.
The idea is you titrate the dose. Now options करते हैं, alcoholic you want to start with the low dose, and then build up the dose as required. So meaning कि alcoholic में तो 0.2 milligrams middle range लगा देना. We start on the same one. Because the problem is they might have a bad liver and they can't, they might have a liver damage. In that case, they won't be able to handle a big dose of midazolam. That's why we always start from lower dose.
Off the record, maybe the record.
No.
I'm sorry, but I'm saying. So you come and you tell me you drink a lot. I'll make sure that is the only colonoscopy that's going to be paid. So that you stop drinking. And then I'll blame the pain on alcohol, not on anything else. That's the only time I allow myself. My first, well, one of the few early bosses that I had in England. Once in the morning I was presenting one of the patients who was a regular overdose. This time it was, she always used to take these antidepressants. And they don't harm you generally. You're woken up in the middle of the night or you're doing something serious and suddenly you get this lady and you do all of it. I was presenting, says, so what did you do? I said, this. Did you even arterial blood gas? All overdose, you must have arterial blood gas. Kind of thing. So that they have liver damage. And so you need to be even more careful using midazolam or something like that. Having said that, there is another extreme. When you're doing band ligation, a lot of people say you can't use sedation. And I think doing band ligation without sedation, especially if you're not doing enough, is a very painful intubation. So I've seen people struggle and not give sedation, whereas I use I'm a little bit liberal in using sedation with my band ligation because they need more than one procedure. The other thing, I think, just nothing to do with colonoscopy so much, but band ligation again, platelet count don't matter. I've seen people not doing band ligation because the platelet is 40,000 or 50,000. They should do band ligation all the more.
I think the thing that we forgot to mention, Saad, is the fact that we use a scope guide here as well, and also we've got the fluoro to help look at the images of the scope. So that's a big thing.
We use an equipment called scope guide. We have the early generation. I think the new ones have some actually better, more user-friendly.
The new ones are more user-friendly because you don't have to be so close to the patients. You can stick them up above. And
well, this is a device genetically with a special scope. I can tell you what the configuration of the scope is. need to do. And then over a period of time, you obviously learn. There are different views about scope guide. We have Bakar who uses it regularly.
Almost for teaching purposes,
Always, but not in your other regular corona.
Even in parameter, if I'm familiar with that, which I not, I'm a big one.
So yes, teaching is a very good tool. We also have to know in the other rooms that we want to see the configuration, we can actually see. So that's how it actually was initially done. And scope guide is in place. Let's try it now. People who have told us what loops are and what's happening in the colon actually did that on when they no, this is magnetic. There's no radiation. The scope has some like 2 centimeters or 3 centimeters. That is then detected by this machine, which then makes it into a figure, and then which actually gives you an idea as to what's happening. So if I have to
Send him a message. I have done. You have? Yeah. Just waiting now to see if.
Learn those things and then also tells you whether you straight but it's yeah, it's very useful for training. It's an addition, but it has to have a special scope. Not every standard colonoscopes don't have the magnetic transformation. The newer scopes have, how many of you are using the 180 system or 190 system? The new system? You have 180? You have this system? 180 used by the experience. And you guys use 180.
Hi, Steve.
Good morning, Paul. Good morning, Karachi.
You're not in the coroners, are you?
No.
You just shocked me with the. Sorry, Steve. I just you look very. You're not going to a wedding.
No, just lots of meetings today. So.
I'm impressed too. Very early in the morning. Good morning, Steve.
Morning, son. How are you?
I'm good. How are you?
Yeah, very good. Thank you.
Steve, can I thank you very much for doing this once again. I'd like you to just have a view around the audience. The people that I'm pointing to on the left are all the candidates, and on this side we have observers who've come from all over Pakistan as well, and they're here with potential for being faculty next year. And then behind the screen over there is Vakar.
Hi, Steve.
Morning.
And for my sins, I've brought Janet as well.
Morning, Janet.
So, Steve, please could I ask you just really to tell us, because you're the manager of a very busy endoscopy unit in the UK, lots of changes, ever so grateful that you can do it, but if you could just give us a little bit of lowdown about how a busy endoscopy unit has to function in the UK these days, you know, if you don't mind.
So, our endoscopy service runs across 2 hospitals. And really there's been a big focus over the last 10 years on quality in endoscopy, and we have this national JAG process that accredits the unit. And that has been a big, massive driver and change for all of us. And we've focused firstly a lot on collecting data and providing evidence that we're doing endoscopy in a way that's safe. So that means a lot of outcome measures, looking at completion rates, complication rates, perforations, and then a whole load of things about patient experience as well, to make sure that the people who are coming through our unit feel that they have a positive experience, that they've been looked after well, treated with respect. The next big driver of change has been as part of the National Bowel Cancer Screening Programme. where in an attempt to reduce mortality from bowel cancer, people are invited over the age of 55 to have an FOB test, and if that's positive, then they get invited for a colonoscopy. And we're really focused on endoscopy quality with that, with looking at things like adenoma detection rates per endoscopist. That's a very individual thing, and retrieval rates for polyps removed, and a number of other quality measures. The big pressure there on the NHS now is on targets, so it's providing efficient, effective services that are really focused around the patient. So when we're requesting an endoscopy, it needs to be done in a timely manner. If we're doing someone's in a surveillance program, that needs to be done in a timely manner. So if they have polyps and we're doing a 3-yearly surveillance, we need to do that on time. We need to be providing a very clean, efficient, friendly environment, and really the current things in order to meet the increasing volumes to kind of extend the working day. So in the past, endoscopy services were very much focused around the staff. So we had a nice 9 to 5 working day, and people had their, sessions, and you come along for your supposed 4-hour sessions. You do a few endoscopies and have a bit of a chat and things. That's in the past, and it's much more focused around productivity and delivering that great patient experience. So we've extended the working day. Our unit's now open 12 to 14 hours a day routinely. It's open Saturdays and Sundays quite often, though not every week yet.
Steve, how have you found that the need, one, for training has changed things, but also how has training affected the productivity in a unit?
So training has effects on us as an individual, because it really makes us focus on our practice. The biggest change, though, for as individuals is teaching and attending these kind of courses, because one needs to focus, be aware of one's deficiencies, and also really learn how to support, encourage, be patient, and communicate what the key things are, and how to move those tricks we use from the unconscious into the conscious zone. In terms of the effect on the unit, we have to be very measured about that. So what we do is allocate dedicated training lists, and we accept that there will be fewer cases on those. And we need to make sure that then we get full value out of those lists. People book on and use those lists. Otherwise, that capacity is wasted. In terms of the effect on the unit and the staff, once we start running these kinds of educational courses, that's of enormous value to the staff, because it adds an extra dimension to the work that they're doing, and they perceive our own unit as now that people are coming from outside to learn in our unit, and from all over the country and overseas. They perceive our unit in a very different way, and we perceive it too. So there are a lot of spin-off benefits from running an educational facility, but it makes us feel much more proud of our unit and what we do, which all contributes to us enjoying our job and doing it well.
The biggest thing about our unit, Steve, which is something that I'm very proud of, is that every one of our senior colonoscopists, endoscopists have all been encouraged to actively participate in upskilling courses. How do you feel that has helped with regards to productivity or the activity in our unit?
Well, I think the individual productivity has gone up, so we've increased the number of cases we would do on a list, and that's come through. That's been facilitated by a number of mechanisms. So focusing on individual ability, upskilling, and all of our endoscopists have either been faculty and teach on upskilling courses or have now attended them. So that's really helped with one thing. We have a much more coherent approach so that we're all behaving in similar ways, approaching problems dealing with polyps, recording and reporting our procedures in very similar ways. So we have a very pooled practice, which helps that. The other things that have helped with the productivity have been around the processes, particularly nursing admission processes, discharging. And because we're doing endoscopy much better, we do an awful lot of it without sedation. So probably 60% of our colonoscopies now are unsedated. And this means that the turnaround is much quicker in the room and the discharge afterwards is much quicker. And there are little things like using CO2 to interflate instead of air can help. But all those things helped. We can get the patients out of the department quicker or out of the room quicker. Then you can get more cases through. But it doesn't need to feel like a production line. The hair's got to be delivered, professionally, and with a bit of tenderness, and people need to feel looked after, and we're trying very hard to achieve that.
The big thing that we've also seen as well, Steve, I feel in our unit, is that it's not just about educating the endoscopists themselves. We're now focusing heavily on educating all the team per se.
That's right. It's very much a team effort, and I do 3 lists a week most week, but all in different hospitals, and each of them has got a pool of staff. So never working with the same staff from week to week, which can be difficult if some of them are not up to speed. And so we really now need to focus our efforts on supporting and training the nursing staff, and we're starting. Some of them have been out to specialised courses. We have quite a lot of input in running regular monthly educational sessions for them, and also just the practice of each other, all being similar, rubbing off on them.
Excellent. Steve, can I just ask you before I throw open to some questions to the audience? These chaps come and ladies come from all over Pakistan. And if you were to try to give them a couple of things, what are the most important things that you feel that they should, for future reference, be most cautious and keep up to date with? Do you think it's their figures, their data, anything in particular you would, as a lead for endoscopy, be looking at people if they were to come to you and say, would you?
The data is just a tool, and keeping the data up to date just needs to be a routine part of your practice. Otherwise, when you get asked to produce numbers, it's a scramble and you're trying to find it. Keeping the data up to date is just a routine, day in, day out, weekly part of your practice. And that data then informs, and you can use that data to enlighten you and guide and direct your training. If you plot your QSUM, look at your completion rates regularly, and it's very easy to do that on I have an Excel spreadsheet that runs in the background saved on the server. Every time I'm doing this, I can open that up, put in the colons and plot my QSUM, and make sure that my completion rate is up to par. And then start looking at the other key things like adenoma detection rate, retrieval rate. Look at the histology reports when they come back. Have you completely excised the polyps? And then look at the quality of your reports. Are they helping you, the referrer and the patient? Really, are they getting the patient through their journey to where they need to be?
Excellent. Thank you very much, Steve. Sarah, have you got any questions for Steve? Because I do realise he's a very busy man.
No, I think you take the question from the
our colleagues, well, I have spent a lot of time with foreign people working in UN, but I can understand that. But
that's not a problem, because what we'll do, we'll talk about, we'll clarify later on.
Also must have some problem. Yeah.
Anything you
I would like to
particularly want
ask that how frequently do you do the procedures over there in your unit? Like how many colonoscopies and endoscopies per day?
Steve, I think what the question is what is the demand for the colonoscopy in our unit? So really, what are the figures and how have they changed in the last 5 years?
So I think last year we did about 3,000 colonoscopies in our unit. We're serving a population of around about 400,000 people, and that figure is growing by about 5 to 10% a year. We're going to have a big expansion next year when a new phase of the bowel cancer screening program rolls out, where everyone at the age of 55 is invited for a flexible sigmoidoscopy. That's going to generate certain criteria and types of polyps will then lead on to colonoscopy. So that's going to add an extra, initially 200 colonoscopies a year. But government plan is that we should be, over the next few years, expecting a 5 to 8% growth every year. There's been a real focus on a shift from upper GI endoscopy, which used to be the bulk of what we do, to colonoscopy. And colonoscopy is a much more useful procedure. We're finding polyps, finding bowel cancer, which is a treatable condition, whereas upper GI cancers, by the time they present symptomatically, it's usually palliative. Early colonoscopy prevents cancer and provides curable cancer. Now, I appreciate the burden of colorectal cancer is much higher in our population than in some others. It's a very real thing for us. So that's where we're at. So we have 4 endoscopy rooms across our 2 sites, and so they're each doing about 1,000 colonoscopies a year. As an individual endoscopist,
Steve,
I do about 400 colonoscopies a year.
And another question that's just been asked, Steve, how many colonoscopies do we have on a list? Really, that's endoscopist dependent. You and I...
So yesterday morning I did a list, and I think we did 5 colonoscopies and 3 gastroscopies. So we're typically running 12 points, where a colonoscopy would be, a planned diagnostic colonoscopy would be 2 points, expecting to take about 20 to 30 minutes of scoping time, and a gastroscopy would be 10 minutes of scoping time, plus getting the patient in and out of the room, checking all the consents, and writing your report. And obviously, if it's a planned major therapeutic colonoscopy, you're going to EMR off a big polyp or something, then we can allow a bit more time for that.
Okay, of course, everybody agrees that experience doing a lot of procedures does have effect on expertise or becoming familiar with the procedure. So what do you suggest? How many procedures should a better or best colonoscopist should do a day to be a good colonoscopy?
I think what he's asking...
I think if we look at our data, and we've got local data, there's national data, there's data from the bowel cancer screening program, and really the tipping point for maintaining quality seems to be doing around about 120 per year. Below that, it's very hard to have good completion rates. So 120 procedures a year seems to be the tipping point for maintaining quality. Obviously, if you're doing 500 or 600, then you're likely to be much better. And I notice this, if I go away on holiday for 2 weeks, when I come back, the first 2 or 3 lists, I'm not as good. And it takes time to get back into the groove, and you've got to keep it handy.
He's always away. I have one... question?
There was a question. You are running a dedicated endoscopy service. A few of us here are from surgical teams. So we are not dedicated endoscopists. It is a part of what we do on certain days per week. So we would never be able to do 120 colonoscopies per year. minimum, probably,
I mean,
each of us.
About half our colonoscopy is done by our colorectal surgical colleagues, and they do meet those things. And they, if you're doing one list a week, 40 weeks a year, then you need to be doing 3 or 4 colonoscopies on that list, and but a lot of our colonoscopy is done by our colorectal surgical colleagues, and they do it very well. We've invested in them. We've put them through the education support, upskilling courses where they've needed to help get them up to the standards. And I don't think there's any reason that it's just a technical skill, and I think you can train anyone to perform a colonoscopy. Writing a really useful report for the referrer is something that requires clinical judgment.
So we just need to keep doing it. We might be a little slow in getting to the benchmark, but we'll get there eventually.
Yeah, what Steve is saying is that even if you're saying as a surgeon you're only doing one list a week, the tipping point is approximately 120. If you have 3 colons and you do 40 weeks of activity a year, 3 colons per list, 40 weeks, that's 120. So at the end of a year, you will reach what is the minimum we would expect to maintain a high quality. Yeah. Steve, I'm just going to say, is that... And that's the point. Steve, if you're...
The point is that if you're doing something that is not up to the mark, would you want yourself to be done by someone who is not up to the mark? And if the answer is no, I wouldn't. I would rather go to somebody who is up to the mark. Then I think it's time to think about what to do. You either increase the numbers, go to that standard, or you stop.
I think this is something that I just want to finally, I know Steve's very busy. Steve, if somebody wasn't up to the mark, what are the factors that you would consider then?
So, I mean, this is something that we do struggle with, and we have 2 or 3 colleagues who frequently, when we looked at annual audit, are just not quite at the standards, but that's down from 5 years ago, half the endoscopists. So we've had a big change, and what we've done to help most people is firstly address it openly. So we have a quarterly audit meeting, everyone comes, and the data's all presented unanonymized. There's nothing more effective than seeing your name up in lights against everyone else's name, and that is a very powerful motivator for change. But we've positively supported people. We've chatted to them all. We've offered them upskilling courses, support. We've looked at their list, the volume they're doing. We've made adjustments where we can to help them get through things. If people are just a little bit away, then with help and support they can usually get there. If people are a long way off, then you have to have a much more serious conversation with them about whether they're going to continue and meet the targets or whether they're going to stop. Because if you're running a unit and you're trying to provide the quality of patient care, and if you've got people who are providing service in that unit who can't deliver, then you can't tolerate that. So you have to either get them up to speed and quickly, or stop their practice.
Thanks very much, Steve. Saad, anything you'd like to add? Steve, thank you very much, my friend. And
Not at all. Nice to talk to you. Goodbye.
Thank you very much, boss. Enjoy yourself. You look like you're going to the coroner.
What happens if you're not up to the mark? Their unit, what they do, and this is not just their unit. There is a big change in UK over the last few years. So what he was saying was, for those who may not have understood, what he was saying was that they would have their quarterly meeting where their figures were put up. Everybody in their unit is being monitored, is being assessed as he's doing his procedures, whether they are senior or junior. Correct me if I'm wrong.
They're called KPIs, key performance indicators.
Okay. So they will be looking at those key performance indicators, and they would be presenting. So there are 5 of us there or 10 of us there. We have our numbers, and that it's put up on the screen where you stand compared to your colleagues. And if you are at par, great. If you're a little low, then what he said was there would be support systems. Support systems, i.e. you can go to Paul. Paul can help you out with some of the issues you're having, or you can go even outside, attend a course or whatever options they have.
Before
But
I
if
went to Kingsmill, which is now 4 years ago, what he was talking about is over 50% of the colonoscopists were probably only getting to the cecum in less than 80% of the time. Now, if we look at the number of colonoscopists we've got 2 who are just below 90%, only 2. Everybody else is 93, 94, 97. Anybody who tells you they're 100%, they're a liar.
Okay, so and if you are way short, you know, you are way far away from your colleagues, then there's a problem. So what he was saying was, then you sit down and see whether you really, what are the issues, and whether really it's worth continuing, because we all can't be good at everything. We may be very good at surgery, but that doesn't mean we can put the tube very well. Similarly, we may be very good at putting the tubes, but we might be useless in surgery or other things. So you need to see, it's all about providing what I told you before, safe, quality care, which is safe, which is at par with what the international standards are, and the best for your patients. Okay, so that's one point that came out from there. The other point was, you know, 3,000 colonoscopies a year. 3,000 colonoscopies a year is a huge number. Now, this is only catering for 400,000 people. Wait, no, they have got 4 endoscopy suites. You know, what he meant was 4 endoscopy rooms in different hospital setups, because they have more than one hospital, but 4 endoscopy suites. But it's only 400,000 people they're catering for. You know, this is a city of 22 million people. Okay, and so, you know, our numbers can be phenomenal if we were, but he made a very important point. Their screening is now established on the basis, basically because of the fact that they have high incidence of polyp cancer sequence. So they want to go in and stop that, and they've shown that it's worth doing it. Is that applicable to our population? At the moment, Asia Pacific group is very seriously looking at it, and now in Asia Pacific, the recommendation is similar. I'm part of that group, and I think we are getting the data from our Far Eastern guys. India and Pakistan still, we don't have that, but I think there is no reason to believe that in the next few years, Pakistan and India and Bangladesh and other parts of this, you know, the Asian Pacific group would also be recommending the same. So the volume of colonoscopy is going to go very quickly. So it's going to increase very quickly. So that was a point that was made, I think, which was important. And it was all about quality. Their focus is about quality. So anything else you do, it's about quality, and that's how they maintain. Turnaround time is important. If you have one scope, they don't have one scope. How many colonoscopes would you have, Paul? Do you know? 14. 14 colonoscopes in that unit, okay, in that department. I don't know of any unit in this country which has 14 colonoscopes, okay. So that's period. We have, so with 14 colonoscopes in different rooms, if you divide it by 4 and they were all doing it, they still have almost 3.5 scopes for each. Okay, so the turnaround time would be different there. You're sitting and thinking 5 colonoscopies in 2.5 hours, 3 hours. The session is 9 to 1 o'clock or 12:30. So 4 hours a session and only 5 colonoscopies. It's because despite of so many scopes, it tells you quality again. Scope washing, scope cleaning, going through the whole thing takes time. It's not about putting it in Sidex, taking it out, and next patient. You do that, they could probably do a lot more. So these are the things that, this is the point we wanted to make. I know the accent, Steve's thing, you need to, you know, obviously if you're not used to it, it's difficult to understand, but that's a problem that you would have with a lot of speakers who speak from abroad. Some of the things you would not understand, and if you don't, that's why we are here to try and clarify that. But in a nutshell, that's what he was talking about. This is the chief of one of the endoscopy units. This is not the largest. This would be one of the good units, average units in UK. For every 400,000 people, they would be doing the same numbers almost, more or less, correct? So, but I think England's shift towards quality is something that we should learn from and try and improve, and that's why these talks are there. They're not going to help you in colonoscopy, they're just going to give you concepts, because tomorrow you're going to be heading a department and you do and you strive to make it better. So now enough of talking, we are hands on, and over to Paul, and all you guys can stand up and come close to him.